Good afternoon. Welcome, everyone. Thanks for joining me. Sorry I'm a couple minutes late there. I was having some issues with the internet, but I think we're good to go now. Right on. Right on. Good. Glad everyone can make it. Just waiting for this to catch up here. I apologize. It was kind of an interesting morning for some tech stuff. So, as you can see, we're going to be covering anterior myocardial infarctions, which was the case this morning. And so we're going to break this down so that way you have a good idea of kind of how all of this works. I'm just waiting for one more camera to get going here. Like I said, the tech issues have been a real struggle this morning, but we're going to get sorted right away here. So what I want to do while we're waiting for that to get up is do a little sound off of where you guys are all from. So go ahead, put in the comments, whereabouts are you watching from in the world? I'd love to see where you all are. And then once we've done that, then we'll get started. Illinois. Bulgaria, England. Oh no. I catch it then. There it goes. Okay, well that's better, isn't it? South Africa, Miami, Portugal. Awesome. It's always good to see where you all are from. Let's see down here. Oklahoma, Northern British Columbia, Kentucky, St. Louis, South Carolina. Awesome. Right on. This is great. Well, I'm glad you guys could join us. I'm glad I got the tech issues sorted so that way we can actually do a class today. So we are covering anterior myocardial infarctions. You'll notice that a couple weeks ago we covered inferior myocardial infarctions. Now it's time to cover the other side of the heart. So let's get into that. Okay, if you haven't seen us before and you're kind of like the way that we teach, use this as kind of your trial run and check us out and see if you like the way that I teach, see if the way you like the kind of the illustrations that I do. Because what we do is we actually offer a premium service for EMT and paramedic students. And what we do is that we just help you get through school. So if you're struggling in school, you want to be the best student that you can possibly be, you want to walk on an ambulance with confidence and understand how to work with patients, that is what we are experts at doing, is that we've successfully done that with tens of thousands of students, and you could also be part of that as well, and you can check it out for free on a 3-day free trial right now. Okay, so let's get into this case. You're dispatched to a male patient complaining of chest pain and shortness of breath. You arrive to find the patient conscious but fatigued on the couch. Okay, so this is your patient, diaphoretic, quite pale. It looks like he's speaking in full sentences at the moment, so that's okay. Okay, so that's what we've got. Now, I'm going to show you the other signs here, and the lung sounds that you hear are quite wet. You hear kind of a rails, crackle sound. So, of course, crackle sound is kind of what you hear. Okay, on the lungs. Okay, here are your vital signs. So your patient has a heart rate of 144, blood pressure 165 on 97 for a MAP of 19. You have a breathing rate currently at 22 to 24, and clearly he is hypoxic at 90 or 84%. Good pleth though, which is probably induced by the perfusion. Okay, so judging by what we see here, what do you think, based off these vital signs in your presentation of your patient, is this patient in a compensated or a decompensated state of shock? Go ahead, put that in the comments. Let me know what you think. What do y'all think? Decompensated, compensated, presentation is on MI? Yes, it is. Presentation is on anterior myocardial infarctions. Y'all think it's compensated, compensated, tachycardic hypertensive? I agree. This patient is currently in a compensated cardiogenic shock. Okay, compensated cardiogenic shock. How do we know that? Well, we know that by the fact that they are tachycardic, which is a sign of compensation. Their breathing rate is up, which is a sign of compensation. And currently they are hypertensive. And so we know that they are currently perfusing. And so in this particular situation, the patient is compensating for the shock that they're in right now. Okay, so this is the ECG you get. Okay, what do you see in this ECG? Go ahead and throw that in the comments. What do you see in this ECG? I'll sharpen it up for you guys on Facebook here. There, what do you guys see on that ECG? Yeah, anterior MI, but what is showing you? What's talking about an anterior MI? Like, what do you see? That's okay if you're an EMT. We're going to talk a lot about some pathophysiology that will be pertinent to you. You see a STEMI, but where? What are you seeing? Elevation in V3, V4. V3, V4 elevated. Okay, I'm inclined to believe with or agree with you is that we do have elevation, particularly in V3, V4, and a little bit in V2. Remember that the rule is that you need at least 1 mil of elevation. What are you doing? Come back here. Okay, you need 1 mil of elevation. So let's go back to this ECG for a sec here. Here, what do you see here is that we have about, this is your isoelectric line, and then your J point is here. You got about 1 mil there. This is pretty obvious. This is your isoelectric line here, and there's your J point. And so that's over 5 mils. V4, you have 5 mils again. V5, maybe half a mil. So you obviously have your confirmation from V3, V4, which is your anterior leads. And so what does that mean is that V3, V4 is looking directly at this portion of the heart, right here at the left anterior descending vessel here. This left anterior descending artery is what it's looking at, V3, V4. So when you see S&T elevation in V3, V4, that's telling you that you have an infarct right smack dab dead center of that left anterior descending artery. That's how you can tell which vessel is most likely involved. So that's what we know so far. We have a STEMI, okay, and it's involving the left anterior descending artery. Now, let's talk about that pathophysiology. Okay, so what exactly that means is that you have that left anterior descending vessel kind of comes down like so. Okay, it comes down right in front of the anterior portions of that left ventricle, and the branches of it come across into the septum, into the lateral portions of this left atrium or left ventricle. And so what essentially happens when you have V3 and V4, that left anterior descending vessel that's blocked, is that this ventricle itself has much more difficult time pumping blood. Okay, and this ventricle is responsible for pumping blood through the aorta, through the rest of the body. So it actually has a really important high pressure job, or we start to have significant faults quite quickly. Okay, and just to kind of give you a visual representation of how this all works and why we hear crackles in these types of patients is because, like I said, the whole design of this ventricle is to fill it up with blood, and then it collapses really, really quickly, and then it pushes blood to the rest of the body. However, when we have an infarction, what happens is that ventricle can still fill with blood, but we can't squeeze it. We can't push with it because that tissue is now ineffective. It's now dying, and it can't move blood anymore. And that's what leads to a back pressure, because it's going to fill up this left ventricle. It's going to still continue to get congested. It's going to start to fill up that left atrium. It's going to start filling up the pulmonary veins that are leading blood back to the heart. And then finally, as you're probably guessing, if you follow the track back, it's going to start filling blood up into the alveoli and fluid into the alveoli, because that pressure problem is so tight, because that right ventricle is still pushing blood to the alveoli to get oxygenated. It still needs to do that job, but we can't move blood from here to here. And so ultimately that fills fluid in the alveoli. So that's where we're seeing some major problems. Okay? So let's talk about some treatment that we can do for this patient now that we know a little bit of the pathophysiology. The first thing is oxygen. Is oxygen indicated in myocardial infarction patients? Okay, as crazy as that question might sound, it is, believe it or not, controversial because of some myths. So go ahead, go throw that in the comments. Is oxygen indicated for this patient? Yes or no? Whoa. Is oxygen indicated? This patient, yes. Does the mitral valve not act as a blood flow backup pressure? No. Well, basically what happens is that left ventricle gets filled up with blood, and then that mitral valve is still opening with every single beat. Okay? And so even though it's still functioning, it still will cause some back pressure or limit back pressure. It's still opening, and so when you have blood that's not even if your ventricle is full of blood and you have so much pressure of fluid in there, when your mitral valve opens, blood will continue to move back into that left atrium. You see what I mean? Is that it's not back pressure. So when we still collapse that mitral or that left ventricle, blood's still moving forward through the area. You don't have no blood moving forward, but because of that pressure problem, that mitral valve is kind of becoming is still effective, but during times of opening, pressure so high that blood can't go through. Okay, so most of you are saying that oxygen is, yes, indicated in this particular patient. I just took out my microphone. And I would agree with you, is that this patient with a saturation of 84% is saying that this patient has an indication for oxygen. Well, what if I change the saturations to, say, 94% or 95%? Would you say that it's indicated then? Then I think that we'd have a different conversation. But the fact is that the evidence that we've talked about, and the evidence that's been talked about for quite some time, is that oxygen can be withheld in cardiac patients if the saturations are above 94% and they are not short of breath. Our main complaint with this patient is that they were short of breath. And so if you have a patient that is short of breath, regardless of your SpO2, oxygen is indicated. So just because you see a good number on your SpO2 doesn't mean we withheld oxygen. You don't go, they're fine, don't give it to them. Look at the whole presentation of your patient. Your patient is short of breath. Your patient is diaphoretic. They're in cardiogenic shock. Even if they had an SpO2 of 94% at that moment, that is a patient that's indicated for oxygen. Okay? And when it comes to hyperoxygenating your patient, I want to kind of hit this nail on the head maybe a few more times into the wood. The evidence that we have didn't show that we had increased mortality or increased infarct size by giving oxygen. Okay, what the evidence showed, and this was a very large centered thing over in Europe, is that what it showed is that there was no effect. There was no impact between patients that got oxygen that were not short of breath, and patients that didn't get oxygen and they were not short of breath. Okay, as soon as you had shortness of breath, they weren't even part of the trial. Okay, but those patients that had a SpO2 above 94% and they were tracking them, and patients that had of 100%, there was no change in mortality. Okay, there also wasn't a benefit. That doesn't mean that patients that were getting oxygen were having more mortality either. Basically, what the evidence conclusion was is that we can save oxygen and save money by not giving oxygen. Okay, because there was no mortality benefit. That's it. Okay, so you are not hurting your patient by giving oxygen if you feel they're short of breath and have a regular SpO2. You are not hurting them. Okay, there is a theory out there is that if we increase the oxygen concentration in the blood that's not bound to hemoglobin, that means that we're going to increase free radicals, basically oxygen that is not connected to hemoglobin, which ultimately can cause vasoconstriction. Okay, that's it. But again, that is a long-term, down-the-road problem that's not really our concern. Okay, it's not even an ER concern. This is like an ICU acute ward concern. So if you have a patient that is short of breath, or you feel that they are in shock and they require oxygen, you're not hurting your patient by giving it, even if they're above 94%, period. Okay? So, now that I've hit that nail, let's continue. Where am I here? Okay, so next portions of the treatment. Obviously, ASA is going to be a medication that we're going to use in this circumstance. Okay, that makes sense. ASA is given to, or acetylsalicylic acid is given to basically any patient that has any type of myocardial infarction. So that's a given that we're going to be giving ASA. Okay. The next thing will be nitroglycerin. Okay. So nitroglycerin in inferior MIs is controversial, but now we're seeing that it's not nearly as dangerous as we once thought. In an anterior myocardial infarction, that's where nitroglycerin gets a chance to shine. Why is that? Well, nitroglycerin, okay, is a benefit to these patients because of its effect. Okay, and so in this patient, I'm just going to skip this question, okay, because we kind of gave the answer. But in this patient, we have a pressure problem. We have a left ventricular pressure problem, and we have a right ventricle that's still trying to send blood to the lungs to get oxygenated. So we have a very serious pressure problem that's causing pulmonary edema, that's causing even more effects on that left ventricle. Okay? So what nitro does is that it's a venodilator, okay? It's a vessel dilator, and by causing vessel dilation, we actually have an impact on preload, and preload is the amount of fluid, okay, generally speaking, is the amount of fluid that's in that ventricle prior to contraction. And so by giving nitroglycerin, what we're doing is that we are reducing preload. Okay, we're reducing preload. And by reducing preload, it means less fluid is going to come to the lungs. And if there's less fluid that comes to the lungs, ultimately, hopefully, should decrease some of that fluid that's inside the alveoli. Because if there's less fluid moving this way, it means that there's less traffic jam in the alveoli. Okay, so that's how nitroglycerin works. Now, there's a lot of things like, well, doesn't nitroglycerin cause vessel dilation around so that way blood can get past the clot? Not in a STEMI. A STEMI is a full vessel occlusion. It doesn't matter how much you try and venodilate that, you're not going to have an effect, okay, on vessel dilation and blood flow around that. You might get some collateral circulation if you're lucky, But the point of nitroglycerin has nothing to do with vasodilation of those coronary arteries. What it has an effect on is preload that allows for a reduction of pressure problem in the alveoli. That's why we give nitroglycerin in patients that have pulmonary edema due to left-sided failure. Okay, so there's another medication, or another, shouldn't say medication, there's another intervention that we can use in this type of patient. What do you think that intervention is? Go ahead, put that in the comments. What do you think about, what else can we use in order to help and treat this patient? Go ahead, put that in the comments. It's not a medication, but it's an intervention. Do we teach classes? We do. We have a full premium membership, my friend. And so you can check that out, the link in our bio. And you can get our books, you can get our premium membership, you can get whatever you want if you want to learn more from us. Nitro, what else? Head up, sure. There it is. That's what I was looking for. We can give, I like positioning. I'm okay with positioning. I think that's a good thing. But I see it now. Saw the answer. And that is, we can give CPAP. Okay? We can give CPAP to this patient. So how does CPAP work? Well, CPAP, I'm moving on here. I'm getting ahead of myself. CPAP works in creating pressure within the alveoli, okay, within the lungs where that fluid is. Okay, and so how does CPAP improve on that? Is that it's going to do a couple things. First thing it's going to do is it's going to put pressure on the superior and inferior vena cava. So like we saw with nitro, it's actually going to reduce some preload, just in a different mechanical way. Instead of causing vessel dilation, we're kind of just pinching the straw a bit in order to reduce some of that preload. So that's the first thing that CPAP will do, and that's all due to intrathoracic pressure increases. The second thing it does is that it improves or increases PEEP, or positive end expiratory pressure. That's the amount of pressure that we have against the walls of each alveoli. By increasing that pressure and expanding alveoli, we're not going to reduce the amount of fluid in there, okay? That's what pinching the straw is going to do. But what it does is it expands the alveoli, which means that there is more surface area unobstructed by fluid. Okay, so the fluid stays in there, okay, and over time it'll get cleaned out as pressure starts to be restored and be better, mostly after that ventricle is fixed and PCI happens. But what CPAP is going to do for these patients is it's going to expand the alveoli, meaning that there is less surface area covered by fluid. And the more unobstructed surface area, the more we can exchange oxygen. Okay? So CPAP is a big benefit for these patients and reduces some of that oxygenation issue that we have. In fact, we likely would see a huge bump in saturation if we can get them on CPAP. Okay, so that is another treatment that I would highly suggest if it's in your scope of practice. And the last thing is that make sure there's no contraindications. The biggest contraindication for CPAP is that they are hypotensive. If they are hypotensive, pinching these vessels that are returning blood to this right ventricle and decreasing preload can cause further hypotension. Okay, so the contraindication of CPAP is the same as nitroglycerin in the fact that they can't be hypotensive, or you could cause further hypotension. Okay, and that is CPAP and using it. And I tend to say use it aggressively, use it early, because the earlier you use it, the more likely it's going to be a benefit, because the less likely your patient's going to be altered, they're going to not tolerate it, and they're not going to be hypotensive. So the earlier you can utilize CPAP, the better it is for your patients and better it is for being successful, okay? Because the longer you wait to pull the trigger on that, the more likely your patient's not going to tolerate it, or it'll now be contraindicated, and you could save them from going that way by using CPAP. So I highly recommend being aggressive with CPAP as long as there's no contraindications. Okay. All right, any questions from you all on an anterior myocardial infarction, whether it was the treatment, the pathophysiology, or things that I've seen? So go ahead, throw that in the comments if you have any questions about an anterior myocardial infarction. If they can't tolerate CPAP, can we do a BiPAP? BiPAP will be fine too in these patients as long as it's not contraindicated. You still create intrathoracic pressure increases. And with BiPAP, it's not nearly as severe because you're not forcing air on both inspiratory and expiratory, which you are with CPAP. BiPAP is a little bit more tolerant, but you still have some of those. And so I have seen patients that have been borderline tensive, like 100 on something, and put BiPAP, and I've seen them deteriorate. And so a lot of the time, if you have a patient, regardless if you're using BiPAP or CPAP, is that we would use a vasopressor like norepinephrine in order to increase that blood pressure. That way we know that they can tolerate a slight decrease. All right, any other questions? Just checking out Instagram here. What if they were unstable, pressure failing, mental status deteriorating? That's a good question. So let's kind of turn the tails of this patient. They waited too long to call EMS, and now they're deteriorating. What do you do in those cases? Let's say they're hypotensive, they're hypoxic, they're really, really kind of in a kind of peri-arrest situation. In those situations, very, very tricky patients to manage because that left ventricle is failing. What you need in those cases, in these particular situations, is time. And you have about this much of it. So in this situation, what I would likely do is that I would want them on oxygen, just oxygen, not CPAP at this point. I would still use my ASA and make sure that I'm using my ASA, and then I would probably go to a vasopressor. So you may not have this option, but I would probably be looking at going to something like norepinephrine and increasing, causing vessel squeeze, increasing that pressure to buy me some time. I'm not going to be using fluid or anything like that. I'm just going to use a vasopressor likely in that situation. And then from there, I would probably, if I can get the pressure up high enough, I would love to get this patient on BiPAP or CPAP. And if I can get the pressure up high enough with my norepinephrine. All I'm doing in these like situations is like I am literally just buying myself time to get them to an angiogram and a PCI and remove that clot and hopefully restore some of that blood flow to that left ventricle. That's all I'm doing in those like rapidly deteriorating situations. Is getting that perfusion up high enough that can maybe help their hypoxia with some CPAP if they're not altered. And if they are, then I might have to go down the BVM route. But that's pretty much your only play in that situation. What about morphine? I'm more of a fentanyl guy myself, and so I usually go the fentanyl route for pain control on regardless of what patient it is. Again, it depends on your protocol. My area and my kind of practice is more on using fentanyl 99% of the time over morphine in these myocardial infarction situations. In most situations, any pain control situation, I either use ketamine or fentanyl. So I've kind of stopped using morphine for the most part because fentanyl is just, in my opinion, a more synthetic, better pain control medication than morphine with less side effects and nauseation effects and stuff like that. So and from a pain control standpoint, I usually go fentanyl over morphine, but morphine often very tolerable and also totally appropriate in this situation. Anything else? Just gonna walk around here. Fluid will make it worse. So better than I would say an inotrope. Absolutely, will be better Where I work, we can only use fluid. Should we position and hold? I think that fluid in this patient would be fairly scary. Again, we have pulmonary edema, which means that we already have a pressure problem. That's okay, that turned off. And so in this situation, I think that if you're going to use fluid, because it's your only option, you're going to use it as sparingly as you possibly can to buy yourself time. But you're kind of putting yourself in a cycle of problems with it because you already have a significant pressure problem. And your hypoxia is due to obstructed alveolar space. And by adding fluids, you're creating more obstructive space. So it's really a bad situation to be in if you don't have the tools to help them. In that situation where you have nothing else, ASA, treat their pain if you can, and then if you need to, use a BVM, and then if their pressures will sustain it, CPAP. But if you don't have a pressor, particularly something like epi or ideally norepinephrine in those situations, it becomes kind of a big problem. And even more so, you would want something like milorone or dobutamine for your inotrope situation, while you can use it for norepinephrine for your alphas. There's a lot of complicated pharmacology that goes into these patients as they're deteriorating. And so I've seen those types of patients because that's my realm of things. I fly, so I see those things on a regular basis, but I know that ground is a little bit limited in what they can do. But in this situation, to answer your question, fluids will probably put you in a bad cycle, but small amounts, maybe just to sustain a little bit of blood pressure. But man, you're putting yourself in a kind of a tough cycle. And so the best thing for this patient, get them a critical care team or get them to the hospital as soon as possible. Even a rural hospital will have the medication they need in order to buy this patient time with vasopressors, right? That would be my 2 cents on that. Sorry, it's not a great answer. If you use fentanyl, do you have to use Zofran with it? No. Fentanyl is really tolerable. I don't think I've ever seen a fentanyl-induced nausea. I've seen tons of morphine-induced nausea, but I've never really seen a fentanyl-induced nausea. So no, I have never used Zofran for the singular purpose of giving fentanyl. Patient is sensitive to epi. What do you use? A norepinephrine would be the one. Epi is not a terrible medication, but again, by using epi in this situation, is you're increasing the heart rate, which increases myocardial oxygen demand, and obviously we have a detrimental oxygen problem. And so I would say top of the list would probably be norepinephrine. Middle of the list would be epinephrine. You really don't have other options in these situations. Okay. Any other questions? I'm just going to walk around and see. Dobutamine, I like dobutamine. I'm a fan. It's kind of old school. But yes, I've been known to use dobutamine. I've been known to use dobutamine in these particular situations in left ventricular failure. But I combine it with norepinephrine because dobutamine is a pure inotrope. It'll cause ventricular contraction or harder contraction. It will have nothing to do with the vessels. And if you're going to cause ventricular contraction to be harder, then you need the blood supply to support that. So if you're using dobutamine, you almost certainly are going to need a norepinephrine. All right. Any other questions, comments? I don't think I see anything else. Norepinephrine increases oxygen demand on the heart, so isn't it contraindicated? No, but you got to think. I want to kind of address this question. Okay, isn't norepinephrine contraindicated because it's going to cause a myocardial oxygen demand? So any medication that you give, there's a risk and there's a benefit. Okay, that's how we decide what we're going to be giving to these patients. Okay, no medication has all benefit and zero risk. That just doesn't exist. Okay, in emergent settings. And so anytime that you're choosing to give a medication, and this is how I teach it to all my paramedics that I teach, is that if I am choosing to give a medication as in an emergent setting, I need to know that the benefits outweigh the risks. If the risks outweigh the benefits, then that medication isn't going to be given. So to answer your question, isn't norepinephrine going to cause increased myocardial oxygen demand, meaning that it's going to be contraindicated? So that is a risk. But if I don't give it, then my patient is going to deteriorate further and I'm going to lose my time and this patient's going to arrest. Okay? So the benefit in giving that is that I buy my patient time in getting them to the hospital so they might not arrest. So my benefit is, in that particular case, higher than the risk. You see what I'm saying there? Is that, yes, you're going to be increasing myocardial oxygen demand. Okay, risk. But your benefit is higher than your risk in that situation. Okay, that's how I make decisions on medications like that. Okay, you're in a very tricky situation. This patient could very likely arrest. Okay, regardless of what you do. And a large portion of the patients that we work with in the ICUs that we're transporting, that decision is made to give norepinephrine and to try and buy this patient time, because my transports are 3 hours, and that patient will arrest before we leave because of that. But again, it's because we chose to give that medication because we felt the benefits were higher than the risk. Does that make sense? Yeah, and these patients, all we're doing is we're racing against the clock. And we think that trauma patients is a race against the clock. These cardiac patients are probably worse. Am I worried about pleural rigidity when pushing fentanyl? Not in an adult, but it's certainly a thing that you can see in neonates. All right, I don't see any other questions there, so I think I'll let you go for now. So thanks again for joining me for the last half hour. If you ever have any questions, you can always throw them in the comments. More than happy to chat. But yeah, thank you for all the very interesting questions. There is a lot of interesting stuff with these patients. I chose one patient that wasn't deteriorating yet because I think that there's a lot to talk about there, and understanding that patient can deteriorate very quickly, which means that you have very limited time. But I do enjoy the questions about what if this patient does deteriorate, because you go from 5 tools to about 1, okay, if this patient does deteriorate. And so the idea with these patients is to be aggressive in your treatment and to use your best treatments early, so that way you keep yourself with 5 tools to keep this patient from arresting. And that way you don't limit yourself to only 1 if they do go hypotensive and peri-arrest. So lots to think about. But again, if you have questions, please feel free to reach out. Okay? Thanks again for joining me. And hopefully you guys are interested in becoming Master Medics members and learning more from us. If you are, check it out, the link in our bio. And you can start a 3-day free trial right now if you want. And you can see for yourself whether you like the way that we teach or not. And if not, cancel. You won't get charged. Okay? Thanks again, and we'll see you next time.